Okay, so today we'll talk about mainly the evaluation of rotator cuff and impingement. If there's any doubts in between, please feel free to turn on the audio. We'll look at the anatomy of the rotator cuff. So if you look at the anatomy of the rotator cuff, it's comprised primarily of four muscles. And the four muscles are, there's one main anteriorly, which is the subscapularis muscle, and that has both a tendinous part and a muscular part. And it has these two parts which are attached on four facets onto the lesser tuberosity and onto the greater tuberosity at the superior part. So that is part one, and then there are four other parts that have the attachment onto the LT. And onto the greater tuberosity, mainly on the anterior facet to the greater tuberosity, you have the supraspinatus muscle. And posteriorly, you have the infraspinatus and you have your teres. So the main thing about your rotator cuff, the way it functions, is you'll have to understand about the pathobiomechanics of the shoulder. So the main thing about the shoulder is that it's not just about the muscles, it's more about the vectors, the horizontal and the vertical force vectors, which together act as a force couple. And so you have your stability and the shoulder function that is maintained by, right? So like I was talking about it, your concavity compression effect. So take this as your horizontal force vector, and this as your, this is your coronal view where you're looking from top, an axial view where you can see the subscapularis anteriorly, your infraspinatus posteriorly. The teres minor comes a little below that, so you're not able to see that in this cut. So it's your infraspinatus and subscapularis are essentially maintaining.
From shoulder to hand, the upper limb is precision in motion. Starting with the shoulder, maximum mobility, minimum stability. The arm, powerful flexion and extension driven by biceps and triceps. Elbow, hinge joint enabling controlled movement and force transfer. Forearm, pronation and supination through radius-ulna coordination. Wrist, fine adjustments, balancing strength with flexibility. Hand, intricate muscles enabling precision grip and dexterity. Neural control, median, ulnar, and radial nerves define function. Any disruption translates instantly into functional loss. Master anatomy, master function. Join MGA to elevate your clinical edge.
Next thing that we're going to look at is, I'm going to just show you a picture that shows you things that we normally overlook. Like for example, when you're looking at an axillary nerves function, most people, or we are taught to look at the regiment badge sign, to look for the axillary nerve, and also to look for just the traditional abduction to see if your deltoid is functioning. But if you look at the axillary nerve, your axillary nerve comes out from the brachial plexus, and when it divides into your anterior branch and your posterior branch, right? So your anterior branch is what causes your abduction and your forward flexion to a certain extent. So if you look at only that and you're not examining for the posterior side of the deltoid, which is this test, which is the Hertel's deltoid extension lag, in which the examiner sits behind the patient and the patient's arm is in internal rotation and in extension, and they are asked to maintain this. If the patient's not able to maintain and the arm drops, either that, or if the patient's holding there and the examiner gives us gentle amount of pressure and they're not able to withhold that against pressure, that means your posterior aspect of the deltoid, which is supplied by your posterior branch of axillary nerve, is weak. Right. So this is also one examination that we overlook, but it has to be done. So that's why I put a picture to bring that to your attention. Right. So when we're looking at evaluation, what are we going to look at? We're going to look at how we evaluate for impingement first, and then for the rotator cuff. And so I'm going to concentrate a little more on the clinical examination aspect of it, because that is the most important, and that is something that will tell you about the patient's inability to do certain things or the
shoulder pain? Think impingement before jumping to rotator cuff tears. Impingement occurs when structures compress in the subacromial space. Start with inspection, posture, scapular dyskinesis, muscle wasting. Localized tenderness, AC joint, bicipital groove, supraspinatus. Assess active range. Painful arc between 60 to 120 degrees is key. Perform Neer's test. Passive forward flexion reproduces pain. Hawkins-Kennedy confirms internal impingement. Add empty can test. Check supraspinatus involvement. Always compare bilaterally. Don't miss subtle asymmetry. Clinical tests guide you, but correlate with imaging when needed.